Hi, I'm Craig Whitman, and this is the talk on treatment of posterior semicircular canal benign paroxysmal positional vertigo, or BPPV. And I'll just say at the outset, I'm fully aware that some of you may question my decision to wear a mask for a live stream, but what the experts are telling us at the moment, 29 October 2020, is that the increased use of masks in the United States in the next several months has the potential to save a lot of lives, and I'm for saving lives, so that's where I'm at. I also want to just take a moment to thank the Hoag Hospital Pickup Family Neurosciences Institute for arranging this talk, which is part of their usual education series. This is an offshoot of that series, and I appreciate their scheduling a talk on vertigo, something that I'm very interested in. If you want to learn more about the Institute and what they're doing with memory, I have another talk on the same channel, the Hoag Health channel, that you can find by searching Whitman and Hoag and memory. But today I want to talk about vertigo, and I've treated a lot of patients with vertigo over the years, and I'm going to talk about the diagnosis of benign paroxysmal positional vertigo, or BPPV, and the treatment, and we're going to save some time at the end for questions. So the typical symptoms of a patient with BPPV are positional vertigo, and so typically patients will find that upon adopting certain positions like lying down in bed, rolling over in bed, or extension of the neck while upright as while getting something off a top shelf, the person will experience strong waves of dizziness and lasting typically 10, 15, 30 seconds, maybe a bit more. But I should note that the strong waves of dizziness that people get with these classic position changes are not the only form of dizziness that these patients get. They get other feelings too, difficult to describe feelings in the head, lightheadedness, balance problems, even walking problems. BPPV is a risk factor for falls. So I have patients that come to me having been told, yes, I have positional vertigo, but I have vertigo when I'm up and around walking, or I have other non-classical forms of dizziness, so I've been told, no, you can't have BPPV, and that's not true. You can have many different types of symptoms and different forms of dizziness. It's just that the most striking and most recognizable form of dizziness that people have with this condition is the strong waves of dizziness, or translating that into medicalese, we call that paroxysmal positional vertigo. Vertigo just means a false sense that your environment is moving or spinning. Positional vertigo means that the vertigo happens in certain positions or with certain position changes. Paroxysmal means that it's a wave or a phenomenon that comes and goes with some lifetime. And the B part of BPPV, benign, is a historical designator. It has to do with many years ago when there was this type of vertigo that was considered relatively benign compared to other causes like stroke or other more immediately devastating conditions. But the truth is that BPPV can be pretty devastating. People lose days of work, lose days of school. It's possible to have balance problems, as I mentioned. So it's really not always that benign, but the good news is that there's a straightforward approach to treatment, which in my experience virtually always works really well. So I'm going to talk about that. So what we do in the clinic and in the hospital, and what patients see when they have BPPV, is that they have these symptoms, and then they come to the doctor and patients tell us that they have these symptoms. And then the way we confirm the diagnosis is by physical examination. And in particular, for the common form of BPPV, the test that we do on the physical examination is called the Dix-Hallpike test. And that's pretty simple. It just involves asking a person to turn their head a little bit to one side and then lie down on the exam table with the head bent back just a little bit off the edge of the exam table. And then we watch and see what happens. And typically after a brief delay of a few seconds, sometimes more, up to a minute is about as long as I've seen it. But after a delay, the patient says, oh, whoa, that's it. That's the dizziness I have. And they experience this wave of dizziness that builds up and then goes away. So we call that paroxysmal positional vertigo, or paroxysmal positional dizziness. And during that same time frame when the patient is experiencing this paroxysm of dizziness, what the examiner sees is eye movements that are abnormal. And so what we see is this wave of a buildup and fade away of rhythmic jerking eye movements called nystagmus. And depending on the type of eye movements, we can tell which part of the inner ear is involved. So in the most common form of BPV, the posterior canal BPPV, the eye movements are torsional upbeat. And so upbeat means with the fast phase beating toward the top of the patient's head, torsional means turning. So the typical nystagmus in a patient with posterior canal BPPV is it's a burst or a paroxysm of torsional upbeat nystagmus that builds up, it gets faster, and then it slows down and it goes away. And when a physician sees that, they say, aha, I've made a diagnosis. It's almost 100% accurate. If the patient has a classic history, has paroxysmal torsional upbeat nystagmus, and I guess importantly doesn't have other signs, but I mean, even without that latter part, it's the likelihood of this diagnosis is extremely high. And this test, the Dix-Hallpike test, is becoming fairly well known to physicians. What's not as well known, and what I would like to emphasize about the Dix-Hallpike test is that sometimes you have to repeat it a few times. So the diagnostic maneuvers we have, like the Dix-Hallpike test, and actually also the treatment we have, the APLEY maneuver, all those maneuvers can do is move debris around, and we'll talk about the debris, that's the main problem, but all these maneuvers can do is move this freely floating debris around the inner ear and out of the semicircular canals. But if the debris happens to be in another part of the inner ear on the day that the patient comes in, like let's say it's sitting in the utricle, the doctor may not see anything. And the treatments, there's nothing to treat because you've already met your goal of getting debris out of the canal into the utricle. But the problem is that same patient can come back the next day and have vertigo again because the debris has moved back into the semicircular canal. So what I'm trying to get at is that there's a certain amount of persistence that's required with this diagnosis, both in diagnosis and treatment. And we may get into some other diagnostic issues in the questions as well, but I want to give an overview first of the treatment. So treatment of benign paroxysmal positional vertigo is fairly straightforward. The first step of what I think is the best treatment, the APLEY maneuver, is the same as the Dix-Hallpike test. So we ask the patient to turn their head toward the affected side, like if it's the right ear, turn the head toward the right side, and then lie down off the edge of the table. We see the jumping eye movements. We say, aha, we have a diagnosis like we just talked about a minute ago. And then what we do is we just leave the person with the head slightly off the edge of the exam table toward the right side, and we roll the head to the opposite side so that now the patient is in the head hanging left position. Stay there for another 30 seconds or so. And then we turn further so that the patient is looking down almost toward the ground. And I'll show you in a moment why this works. But what you're really doing is you're moving this debris that shouldn't be in your semicircular canals around the semicircular canal where it's trapped. So I think what I'll do is to show you a model of the inner ear to explain a little bit better what we're doing with that. So I'm going to try to bring this up to the camera here. This is a model of the inner ear showing the vestibulocochlear nerve heading off toward the brainstem, which is not shown in this picture, but interesting to me as a neurologist. And then this side of the inner ear is important for hearing, cochlea. We're not talking about that today. This side of the inner ear is important for balance. And you can see these three loops or rings or semicircular canals that are roughly at right angles to each other. And this back one, which is called the posterior semicircular canal, and I'll turn the ear around so that you are looking at the back of the ear. So again, cochlea, semicircular canals, posterior canal. I'm going to turn it around and maybe I'll orient it so that you can see on the camera. So you can see that this is the posterior semicircular canal, which senses rotations of the head, and this is the anterior semicircular canal, which also senses rotations of the head. This down here is the utricle, which is a linear acceleration detector. So that detects something like if you're in your car and you step on the gas and your car accelerates forward, acceleration parallel to the ground while you're upright is detected by the utricle here. And the mechanism of that involves deforming of this membrane on the utricular macula, which then bends these things called hair cells, which then changes the firing rate of this vestibular nerve. And without getting too far into the weeds, the point I'm trying to make is that a critical part of that mechanism of acceleration detection is that this utricle has this gelatinous layer that gets deformed when you accelerate. And so another way to think about that is that the gelatinous layer of the utricular macula or sensor of acceleration stays put while the person, the car, the head, the ear all accelerate away and leave this utricle gelatinous layer staying put and thereby bend the hair cells that are stuck in it. Well, to give the gelatinous layer even more weight and make it stay put even more and detect the acceleration even better, the gelatinous layer of the utricular macula, which I'll represent by this bar of soap here, has some kind of like stones on top of it. And this is not to scale. The stones are really more like otoconia, and that's the problem which has happened there, the falling off of the rocks. These stones are more like dust. So they're called otoconia, which means ear dust. Some people say otoliths or ear rocks, but they're very tiny. They're like about 1% of a millimeter in size. So you couldn't see them unless you're looking under a microscope. But the problem is that if one or more of them breaks down and becomes dislodged from on top of the utricular macula and falls off and starts floating around in the fluid of the inner ear, now you've got this dust that's trapped in the semicircular canals floating around, kind of like snow in a snow globe. This is probably a better representation. It's more like dust. Where I was showing you rocks, it's really probably more like dust. And you can see how each fleck of dust slowly settles under the influence of gravity. Well, that's part of what's happening in benign positional vertigo. So going back to our model of the inner ear, once again, this is the posterior semicircular canal, which is typically involved in the most common form of this condition. The debris tends to be trapped down here. The dust tends to be trapped down here at the bottom of the semicircular canal. And whether you're standing up or lying down, what happens is it just kind of sloshes around at the bottom of the canal and it's trapped there and it can't get out. So our job in trying to cure this condition is very simply to move the debris around the posterior semicircular canal toward what's called the common crus, the common region of the anterior and posterior canal, and dump it back into the utricle where it came from. So originally the dust fell off of that membrane I was talking about. It somehow floated into the posterior canal. It got trapped down here at the bottom. Our job when we treat patients is to move it back the other way, back around the canal, and dump it back into the utricle. Dump it back into the utricle, and then from there it probably gets reabsorbed or otherwise cleared out of the inner ear. So to do that, we go through those steps that I was talking about. So if the debris is trapped down here, and it's a little hard to show you the positions on the camera here, but basically we have you turn the patient toward the side, and then that puts this back canal in the right position, and then you have the person lie down and you move them around, and essentially you're just moving debris around this canal toward the common crus, dumping it back into the utricle. But the point is that I was making before is that sometimes this requires a lot of persistence. And once again, all we can really do with the APLEY maneuver and related maneuvers is to move the debris out of the posterior semicircular canal and put it back into the utricle where it came from. And if we keep doing that, the syndrome goes away. It's my experience, it always works. It's just that you might have to do it a bunch of times. And I think one of the reasons you might have to do it a bunch of times is that even if you're successful in getting the debris out of the canal and putting it back in the utricle, something might happen. The patient might bend over, stand up again, and the debris might get moved back into the posterior canal and get trapped there again. And then you're back to square one, and you have to repeat the treatment maneuver. One of the interesting questions is about whether there's any role for vibration to try to loosen up this debris and make it easier to move around the inner ear. And although that hasn't really been borne out in studies, I can't really cite any evidence base for that. I can tell you about my personal experience, which is that there are some patients I've treated who, interestingly, have a very long delay in the onset of the eye movements on their physical exam. So these are patients where I have them lie down to one side, and you wait, and you wait, and you wait, and after 25, 30 seconds, finally the eyes start moving, and maybe they move a little bit slowly. And then also the duration of eye movements is very long. They go on for 15, 30, 45 seconds. And what I picture is that debris, rather than moving very freely in the semicircular canals, is kind of stuck in there. And what you want it to be is more freely moving, so you can more easily move it around the inner ear and get it where you want it to be. So what I've seen in a series of people, can't really prove it, haven't published it, but I've seen some of these patients where they have this long latency or long delay before the eye movements start, long duration eye movements, and I just simply took a neck massager type thing and just vibrated over the mastoid bone and back of the ear. I would not vibrate the neck. I would never put a massager on the neck because there's a risk of causing a carotid artery dissection or damaging an artery. But just a few seconds over the skull, and I'm not suggesting patients should do this themselves, but sometimes doctors or physical therapists will try it, just a few little vibrations over the back of the bone and back of the ear. And what I found is when I do that, sometimes the duration and latencies change a lot. So a patient who had a latency or a delay of 25 seconds before the eye movement started on lying down and the duration was 45 seconds, now has only a 5-second delay and the duration is 20 seconds. So to me, that intuitively means I've loosened things up and it's moving more freely. So that's a sort of an interesting refinement. But I think the biggest thing to know that's not part of the common knowledge out there is the persistence, the need to keep treating. And another point is that sometimes patients will be treated for benign positional vertigo, and their symptoms will get a lot better. They'll feel maybe 80% better, and they and maybe their doctors will decide, okay, you're done, you're cured, but the symptoms go on, and sometimes I've seen people where symptoms have been going on for a year, or maybe longer, and I think that sometimes it's important to keep checking a few times over a period of a few weeks to make sure it's gone, because of this problem of you got the debris out of the canals, you put it in the utricle, but it keeps getting back in the canal. So persistence is very important. So I can see people writing down questions. Maybe we should transition to taking a few questions, because I think there'll be more to talk about based on people's interests. So the first question is, can migraine cause this type of vertigo? Well, migraine is a totally different diagnosis and disorder. It's a genetically determined electrical, chemical kind of problem in the brain. On the other hand, BPPV is a mechanical problem in the ear with these crystals or ear dust floating around. There are, however, relationships. Benign paroxysmal positional vertigo seems to be more common in younger people with migraine than younger people without migraine. So there's that. The big thing I see, though, is BPPV can aggravate migraine. So that isn't really the question. So the question was, can you have the same type of vertigo from migraine? And you can have waves of dizziness from migraine. However, they wouldn't be this kind of stereotyped, same duration every time, provoked by the same position every time, reliable triggering of a, for example, 15-second wave of dizziness every time the person rolls to their right side in bed. That's paroxysmal positional vertigo, and I have not seen that as a feature of migraine per se. So another question is, can changes in a person's diet help with BPPV? And I I guess the real answer is we don't know. So these crystals are a complex of calcium carbonate and protein. So no doubt they have a metabolism and they turn over probably very slowly, but we don't understand it very well. So how to favorably influence the metabolism of these crystals and make them stronger and less likely to break down, we don't know. I mean, for a while there was some interest in whether supplemental vitamin D might be protective and might prevent recurrences of BPPV. And maybe there's some parallels with bone, that supplemental vitamin D may be important for maintaining the mineralization of bone. And so maybe there's some way in which vitamin D might help prevent demineralization of otoconia. But it's not really well proven. That being said, I think that people that live, particularly people that live in climates where they are not exposed to as many days per year of sun, as was the case when I lived in Massachusetts, where everyone seemed to be deficient in vitamin D when you checked. I think that people who live in those kind of climates, Boston, Chicago, places where there's not tons of sun, probably should take supplemental vitamin D in the winter, or at least check vitamin D and make sure that it's not low. Because I guess to some extent I'd put the answer to that question in the category of I like to make as many things normal as possible, especially if we don't fully understand the metabolism of the otoconia. Maybe we should do our best to make metabolism as normal as possible. So, so that's the main answer I think that I have for that question. I have another question. Is BPPV fatal? Well, it's generally not fatal, hence the B in BPPV. However, you can have some serious consequences. So I've seen people that were kind of compensated, doing okay with their gait and balance, who developed BPPV and fell and suffered a hip fracture or a head trauma. And so those can be very serious problems. So I guess that's the best answer to that question. I suppose, yeah, that's the way in which BPPV can become life-threatening, is through the increased risk for falls. I have another question. It says, so the question has to do with what if you've had long-standing BPPV for several years and an APLEY maneuver worked modestly well, or okay, but is there a more permanent solution? Well, I think that first one would need to establish that this, I think that the perspective of this question, it assumes that the APLEY maneuver is working only modestly well, or working just okay. And in my experience, you can get the APLEY maneuver to work really well for just about everybody that I've seen. And when I say work really well, I mean get BPPV, the syndrome, to go away for long periods of time, like months to years. I'm not sure if that's what the question was, implying that that's okay, or does okay mean you're not quite back to normal? So when patients tell me, I've had APLEY maneuvers, they work kind of okay, but what else you got, kind of thing. Most of the time, like 85, 90% of the time, the problem is that one of two things. Either the BPPV was not completely treated. So the person was treated once or twice, 3 times, sometimes more. But the debris is still sloshing around there in the semicircular canals and hasn't been fully cleared out of the inner ear. And I think the answer to that is what I was talking about before. Persistence, repeated treatments, sometimes different kinds of maneuvers directed at clearing debris from the horizontal and anterior semicircular canals, which I haven't really focused on in this talk. Maybe we'll have to make another video. But I think that's the first question, is through persistence and repeated maneuvers and maybe variations on maneuvers, can we get the APLEY maneuver to work really well, as opposed to just okay or just modestly well? And in most cases, I think the answer is yes. So if your question is about surgery, it is the case that before this type of maneuver, APLEY and similar maneuvers, were popularized, which is starting like in the mid-1980s. Before that, surgeons did used to do a surgery where they would plug up the semicircular canal where the debris was located. And so that might be construed as a permanent solution, although it's a solution that's knocking out one of your 6 semicircular canals, so it's taking some function away. And more importantly, I haven't ever had to refer a patient for that surgery just because the other maneuvers work so well. I mean, I guess I'm open-minded to the possibility that I might someday meet a patient who's, you know, like, what if these little crystals, they're made of calcium carbonate and protein, right? Like there's otoconins or some kind of proteins in there. What if you had a genetically determined mutation in the gene that codes for that protein? And what if it was so abnormal that the crystals just fall apart all the time? Could there be such a patient that needs a surgery to take out one or both posterior canals? I've never seen such a case. As I say, I'm theoretically open to the potential indications for surgery for BPV, but I've never had to refer patients for it. And you know, that's despite seeing many dizzy patients, subspecializing in this going back to the late 1990s. I just haven't had to do it. So I think that probably you can cure it non-invasively. And again, by cure it, I don't mean that I can stabilize the crystals forever. It might come back, but you get it to go away for months to years. So here's another question. It says, can you learn to do the APLEY maneuver by yourself? And yes, I think you can. I think it's, first of all, far easier to learn from videos than it is from flat drawings. So if one were going to try to learn how to do these maneuvers, it would be, you know, good to watch the videos. I think at least initially, when you're trying to make sure you've got the diagnosis right, which ear is it, which canal is it, which maneuver to do, it is helpful to have somebody who knows what they're looking at look at the eye movements and tell you, yes, it's the right ear, posterior canal, you should do APLEY maneuvers, as opposed to, no, it's the horizontal canals and you should do a log roll maneuver, some different maneuvers. So I think to some extent, yes, patients can play a role. And another thing is sometimes patients need lots of treatments, lots of physical maneuvers, and more than can easily be provided by the doctors and physical therapists that they're seeing. So sometimes healthcare providers do train patients to help themselves by doing some maneuvers at home. Now, I would say that in the last step of any physical maneuver for treatment of BPPV, there's a step where you sit back up, right? And sometimes when people sit back up, they are more dizzy than they think they are, and their balance isn't as good as they think they are. So there's a risk that you might do a home maneuver and then jump up out of bed and try to walk and fall during one of the first few steps. So I think it's probably best to do these maneuvers with another person. So if it's at home, to do it with a friend or family member who can, first of all, help you through the steps and help ensure that the steps are being followed correctly, but also to keep you safe and make sure that you're safe to walk after the maneuver. Here is another question. It says, do you do the treatment in your office or do you send patients to physical therapy? Well, if the patient is in my office and I make a diagnosis of BPV, I'm right there. I already have their head in a position that's the first step of the treatment, so I just go ahead and treat them. I do often enlist the help of a physical therapist as well to follow patients in parallel with me, and there are some patients where I'll do some of the maneuvers and therapists will do some, maybe even the patient will do some at home. One of the advantages of involving physical therapy is that they do balance and gait retraining. So they'll spend sometimes an hour with you, sometimes more, working on your balance and leg strength. And these are things that typically are not so easy to implement in doctors' offices. So I do treat it in the office, and I do also use physical therapists to help. So question about can citric calcium contribute to vertigo? I don't think so. I mean, I must admit, I'm not sure I'm 100% confident what's in that brand, if citrical means calcium carbonate or if citrical means calcium carbonate with vitamin D, but you know, what what one would speculate is that it might even strengthen these crystals and prevent their breakdown. But the real answer is we don't know enough about the metabolism or effects of things you take to recommend for or against anything you take with the goal of preventing BPPV. So the question is about whether practicing yoga can make BPPV worse. So, I mean, as I was showing you on the inner ear model, the treatment that we do for BPPV involves tilting the patient into various different positions and somewhat upside down. And so you, through practicing some poses or postures in yoga, I'm sure if you have debris floating around the inner ear, it's possible that you will move it around the inner ear in some way that may be favorable or unfavorable. So I guess what I would say is that if you're actively in the process of trying to cure the BPPV, in other words, you're actively in the process of trying to get debris cleared out of the inner ear, it may not be the best time to do the upside down kind of maneuvers that you do in yoga. Anything where your heart, your head is lower than your heart has potential to move debris around the inner ear in ways that you don't want to. That being said, I think that exercise is great for well-being and will help your balance system get back to normal. And as soon as you and your provider feel that the debris has been cleared out of the inner ear, then I think, of course, people should go back to their exercise program and yoga, and that's likely to be very beneficial. I have a couple more questions here. Can the use of over-the-ear headphones and the pressure they put on the ear bring on benign positional vertigo? So, not as far as we know. So step one of starting BPPV is you have to have a breakdown of these calcium protein crystals, right, that we've talked about. So a question you might ask is, what about sound waves? If you listen to phenomenally strong, very loud music, could you somehow dislodge or knock these crystals off of the utricular macula and start the whole process? I've never seen that. I think that I might have seen a case report of someone who was standing next to a cannon, someone serving in the military who developed BPPV, if I remember correctly. But that's at the case report level. That's not something that's been studied at the level of groups in a scientific fashion that would allow one to make any conclusions. I have seen things like someone who presented with BPPV after riding a roller coaster, which involves a lot of jarring, banging kind of movement. I can imagine that might be a phenomenon. Certainly head trauma can cause BPPV. If you hit your head, it can cause these little particles to become dislodged from the utricular macula. But headphones per se, haven't seen it yet. I worry about the effects of headphones on hearing. I think it's headphones and loud music, particularly the earbuds and prolonged use, cause, we think, a lot more hearing loss than people are aware of. So I'd be cautious with the loud music. But the direct answer to your question is no, I don't think it's been reported to cause BPV. Next question is there a relationship between BPPV and tinnitus? So tinnitus, is just any sound that you perceive that isn't really there. So you hear a ringing or a static or a roaring or some kind of sound that others don't hear. That's tinnitus. And I think the way I would answer the question is to say that any kind of stressful experience tends to make tinnitus worse. And BPPV is certainly a stressful experience. So I think if you do have BPPV and you've noticed an onset of tinnitus or an uptick in tinnitus, first of all, tinnitus is a strong indicator of possible hearing loss. So anybody that has new onset tinnitus ought to get a hearing test and see whether there's a hearing loss, but it might have implications for treatment. That being said, what if there's no hearing loss and you have BPPV and you develop tinnitus? I think the way to get at the tinnitus is to really work to get rid of the BPPV as soon as possible and to try to bring down stress level however you can, getting regular sleep at night, maybe things like meditation. Stress is a big contributor to tinnitus, so bringing down stress level is really key, and part of that is curing the BPPV. A couple more questions. So one question, is there any harm in doing the APLEY maneuver daily as a preventative? So the word preventative typically means that you don't have the condition now, but you're trying to reduce the risk of having it in the future, right? And whether you've never had it or you've had it recently, prevention means I don't have it now, but I don't want to get it. And the answer is no, because as I've been saying, the only thing that the APLEY maneuver can do is to move debris out of the semicircular canals and put it back into the utricle. And if you're not having positional vertigo and your doctor or provider's not finding paroxysmal positional nystagmus, then I think substantially you don't have diagnosable BPPV, and you don't have debris. It's not likely that you have debris rattling around in your semicircular canals, the best that we can tell, with current medical practice. I don't think preventative is likely to be helpful. It's that the APLEY and similar maneuvers are things that we do if you have paroxysmal positional vertigo, if you have diagnosable BPPV. The other part of the question was, is there any harm in doing the APLEY maneuver? And that's an interesting question. There's not much risk if you have problems with your neck, and especially if you're doing home APLEY maneuvers, and you're manipulating your neck over and over again repetitively, there's some chance that you could injure, for example, a nerve root or a facet joint in the neck. So that's one potential kind of harm. Another possibility is that, and I don't think this is what you're talking about, but if debris is in the posterior semicircular canal and you do the APLEY maneuver in kind of an unconventional fashion, it's possible to spread the debris around to other canals. And what can commonly happen is it gets moved into one of the horizontal canals. And then sometimes the situation is now you've got multi-canal BPV. So you've got debris in the posterior canal where it started out and in the lateral or horizontal canal. And that can be tough and just require more time and persistence in treating one canal than treating the other one. So a question about flight. The question is, what about taking off and landing when flying? So the inner ear that we've been talking about, which consists of the hearing organ, the cochlea, and the 3 semicircular canals, and the utricle and the saccule, which, all of which take care of balance. Semicircular canals, utricle, saccule, balance, cochlea is hearing. All of that, all those components of the labyrinth are almost entirely encased in bone. There are these couple of windows, the round and oval window, that allow a little bit of communication between the inner ear and the middle ear, but mostly the inner ear is encased in bone, and so it's isolated from the pressure changes that you would have in the cabin of an aircraft, for example. The problem that people get into with flight has to do with the middle ear. So the middle ear has this tube that equalizes pressure between the middle ear and the outside world. It goes from the middle ear back to the nose-throat junction. And so if you are, say, landing on a plane, the pressure in the atmosphere rises, and there's pressure on your eardrum, and so the pressure goes up beyond the eardrum in the tympanic cavity, which is the middle ear, and that can be vented through the eustachian tube back to the nasopharynx. But if you have blockage of the eustachian tube, like from allergies or a cold or something like that, then, or in children who have a very small eustachian tube, it doesn't always work, it can be very painful. Flight can be very painful, but that's not related in any significant way to be. They took that card away, but I think that was the whole question. A question I've been interested in is, what if there's turbulence? Could you somehow jar loose some otoconia and start up BPPV? And that hasn't been reported. I haven't seen it yet. So generally, flight and BPPV are not related in any way that we can understand. All right, I think we're going to take one more question, and this question says that I had recommended persistence with APLEY maneuvers, and do I recommend coming in weekly or more often, and how many times total? And I think the therapy really has to be individualized. So it's typical for a physical therapist to have people come in once or twice a week for several weeks. Another point is, in my practice, I usually like to allow at least about 48 hours between appointments, because I figure if I've just done a good job of moving the debris out of the semicircular canals, putting it back in the utricle, it's sitting there in the utricle, we're waiting for it to clear out of the inner ear. If I go back 6 hours later and do the maneuver again, I'm going to tilt the person upside down, and I have a risk of moving debris back into the semicircular canals as a result of tilting the head back. So I think every time you do an APLEY maneuver, there's a risk that any successful APLEYs you've done before that have gotten debris out of the canals back in the utricle will move it back in the wrong direction from the utricle back into the canal. So I like to allow a little time once we've done a round of APLEYs for the debris to clear out of the utricle before we go and try it again. So I think a reasonable, yeah, what you said is reasonable. Well, I don't know if you said this or not, but more than once a week is certainly reasonable. I think 2 or 3 times a week, or like, you know, a Monday, a Wednesday and a Friday, or a Tuesday and a Thursday treatment would be very reasonable to do. As far as how many times total, I think that depends on the patient. The answer is until you're done. And the most I've seen a person need, I can recall a couple of patients where I needed to bring people in maybe 15 times over the course of 6 to 8 weeks or something, and we finally were confident we got rid of it. But that's at the extreme end of where a lot of treatments are needed. It's more common for people who need 1 or 2 visits and it resolves. So I hope that answers that question. Well, I thank you very much for joining our talk today. And as I say, maybe I'll try to post another video